I am Alexa Tinsley. I am the Director of Programs here at Jett Foundation. I want to thank you all for coming and learning more about rhabdomyolysis today. It is something that we get a lot of questions about, and we are very grateful to Dr. Carla Zingariello for helping us make this webinar possible and sharing her knowledge and expertise with us. She is actively involved in MDA research. She is at the University of Florida. Since 2022, she has served as a co-PI on CDC-sponsored muscular dystrophy surveillance studies. She also serves as a PI for a limb-girdle muscular dystrophy clinical trial, and she serves as a sub-investigator on multiple gene therapy clinical trials for Duchenne muscular dystrophy. So before we get started, I do just want to mention a few things. If this is your first webinar series, we do offer these throughout the year. We try to take what we're learning in the community and give you the knowledge that you're looking for. This webinar is being recorded, so if you have to log off or you have heard of anyone who wanted to know more about this topic and wasn't able to attend, we will have it recorded and we will send that for you to share later on. If you do have any questions, please go ahead and use the Q&A box at the bottom. It's kind of in the middle of my screen, actually. There's two little chat boxes. We do try to monitor the chat, but that is primarily where we will be taking questions from. We are also streaming to Facebook Live, so if you do have any questions on Facebook, please feel free to ask them, and we will do our best to get to those as well. So that is all from me, and I will hand it over to Dr. Zingariello to give her knowledge and expertise to share with you.
Thank you very much, Alexa. I'm happy to talk to you today about rhabdomyolysis and Duchenne muscular dystrophy. So what is rhabdomyolysis? So rhabdomyolysis, or rhabdo as it might be shortened to, occurs when large amounts of skeletal muscle break down and release a muscle protein called myoglobin into the blood. The release of cell contents into the blood, especially potassium, can lead to heart rhythm problems and kidney failure, which we'll discuss a bit more. And this on the right here is just a nice illustration showing damaged muscle and how the contents inside the muscle are being released into the bloodstream, which then flows to the kidneys. So what causes rhabdomyolysis? There are a number of causes that can affect people of all ages, including trauma or loss of oxygen to the muscle. An example might be if a tree trunk fell on your leg. Infection, and particularly the flu and Epstein-Barr virus, have been associated with rhabdo. Strenuous exercise or prolonged seizure, and this can happen in healthy individuals. Heat stroke, various drugs or toxins. And then there's a couple of genetic defects. So muscular dystrophy, which we're going to discuss for the rest of the presentation, metabolic myopathy, or a disorder of lipid metabolism. So why are patients with Duchenne muscular dystrophy at risk for rhabdomyolysis? So in Duchenne, the muscle membrane that covers the muscle fibers is fragile, and it's more likely to tear or break down even from regular exercise, and more so if you have another insult such as dehydration or excessive exercise or drug or toxin, and we'll get into those things. So the illustration on the right here shows shows a normal muscle membrane dystrophin glycoprotein complex. And you can see dystrophin there, which is sort of that shock absorber, if you will. And then below that, when dystrophin is missing, like in Duchenne muscular dystrophy, you have membrane instability and calcium can rush into the cell. So what is a trigger for rhabdomyolysis and Duchenne muscular dystrophy? So medications or anesthetics, in particular succinylcholine, which is a depolarizing a paralytic, the halogenated anesthetics, and we'll give you some examples of these. Eccentric exercise, which we'll talk about on the right here, dehydration, and gene therapy that was recently approved can also be a trigger for rhabdomyolysis. So on the right, we have an example of weightlifting exercises. So on the top, when the muscle is contracting, it's what's called concentric contraction. So this is looking at the bicep in particular. And then in the middle, when the bicep muscle is stretched out completely, that's an eccentric contraction. And then where there's no movement at all on the bottom, that's isometric contraction. Now, our problem comes with eccentric contraction, but the way our muscles are set up, we have opposite reactions. So as you might be doing concentric contraction with your bicep, you're actually doing an eccentric contraction with your tricep. So in general, we advise our patients with Duchenne muscular dystrophy to avoid weightlifting, but certainly aerobic exercise like walking, swimming, or a bicycle is fine to do. So succinylcholine. So this is the one that actually has a warning label. So this is a skeletal muscle relaxant used to paralyze a patient's throat to allow for placement of a breathing tube. And it's typically what emergency medical services will have on hand. In the hospital setting, like the OR or other sedation areas, they often have other alternatives. But you can see here, there's actually a warning risk of cardiac arrest from hyperkalemic, which means increased potassium rhabdomyolysis, and that there's been reports of this with ventricular dysrhythmias and cardiac arrest and even death after the administration of succinylcholine to what were thought to be healthy pediatric patients who were subsequently found to have undiagnosed skeletal muscle myopathy. And in most cases, this was Duchenne's muscular dystrophy. Okay, so what to look for? So if you are experiencing rhabdomyolysis, you're going to have dark colored urine, which we'll show you a picture of in a moment. There may be muscle pain or cramping, muscle weakness, muscle swelling, abdominal pain, nausea, vomiting, a rapid heart rate, or confusion. Or there may be none of these symptoms aside from the dark colored urine, but that is enough to say that there's a concern for rhabdomyolysis. So on the right here, you can see myoglobin, once it's released from the muscle that's injured, it causes this brownish colored urine. It's not subtle, so it's more than just I haven't drank a lot of fluids today, dark yellow urine. It's more like a tea color. If your child with Duchenne muscular dystrophy, or any child really, has dark colored urine like this, they should go to the nearest emergency department. Acute management is focused on cardiac monitoring, preservation of kidney function, and restoring electrolyte balances. So why is rhabdomyolysis an emergency? Failure to treat rhabdomyolysis right away can lead to life-threatening cardiac arrhythmias and kidney failure. So the EKG or electrocardiogram on the right here is showing what's called peaked T waves. And that's a sign of hyperkalemia or increased potassium. And that's a clue that the inner cell contents of the muscle have spilled into the bloodstream. And that can be very dangerous for the heart. It can cause arrhythmia and then, of course, kidney issues. So what happens next? Your child will likely require admission to a pediatric hospital and possibly a pediatric intensive care unit to closely monitor their heart and kidney function. Your child will likely require massive amounts of intravenous fluids to prevent kidney injury. When will my child expect to improve? So creatine kinase, or CK, which you may be familiar with when your child was first diagnosed with Duchenne muscular dystrophy. In cases of rhabdomyolysis, it will rise in the first 2 to 12 hours following onset of muscle injury. It peaks around 24 to 72 hours, or 1 to 3 days, and then it will decline to baseline, whatever your child's baseline CK was, in about 3 to 5 days. If treatment, meaning fluids or any other necessary treatments, are started right away and there are no complications, your child may only be hospitalized for a few days. So how can you prevent this? We can avoid certain medications like succinylcholine, shown up there in the top. That was the one to relax for intubation. Inhaled anesthetics, and examples of those are in the bottom box there. Eccentric exercise or weightlifting, and dehydration as much as possible. So this was taken from Berkrant et al.'s article, Diagnosis and Management of Duchenne Muscular Dystrophy, back in 2018. where they talk about anesthesia precautions in patients with Duchenne muscular dystrophy. And they explicitly say total intravenous or IV anesthesia is strongly recommended. Depolarizing muscle relaxants such as succinylcholine are absolutely contraindicated due to the risk of fatal reaction. And they talk further about risk of rhabdomyolysis and hyperkalemia with inhalational anesthetics or succinylcholine. Now, they also point out rhabdomyolysis is distinct and different than malignant hyperthermia, which can be associated with certain other genetic muscle conditions, but it doesn't mean that it's any less serious. Okay, so what is safe anesthesia for Duchenne muscular dystrophy? The IV anesthetics, and there's a number of them that can be used. So that's diazepam or brand name Valium, etomidate, ketamine, methotrexate, midazolam or Versed, propofol or diprivan, diopental or pentothal. These are all commonly used medications in children and readily available at most pediatric hospitals. Nitrous oxide or laughing gas, which might be used by a dentist, and local anesthetics, things like lidocaine, if you had to, say, suture an injury, are also used by dentists. Those are all safe. And then muscle relaxants, so alternatives to using succinylcholine. There's a number listed here. The ones that are most commonly used in practice are vecuronium, rocuronium. And a more complete list is available on parentprojectmusculardystrophy.org. Okay. Does anyone have any questions?
Perfect. Thank you. Yeah, I know that this is a question that we get a lot, like what to look for, my child has brown colored urine. And I think that that's, really, can you explain a little bit more about kind of simply what happens when this muscle breakdown is happening? So you kind of talked about, increased potassium. So I know you have the diagram. So just a little bit more about because you said, it's getting into the blood. So how exactly, what is happening that's causing this?
So the main thing is that our muscle cells are supposed to be contained, right? And not open and with the blood. And so when the contents of the muscle cells, that includes things like calcium and potassium and myoglobin, things that shouldn't, or especially the potassium, I should say, myoglobin, when those are released into the blood because there's a tear in the muscle cell, that subsequently enters the bloodstream. And as we know, our blood goes everywhere. It goes to our brain, to our heart, to our kidneys. And so anything that shouldn't be in the blood or in a higher level than it should be in the case of potassium, right? There's normal levels, but then increased levels. That creates complications because our kidneys can only keep up so much with filtering out things that shouldn't be in the blood. They're great filters, but what happens is the greater the level of injury, it sort of overwhelms that ability for the kidneys to filter out those contents and leading to kidney failure. And then if that builds up into the bloodstream because the kidney can no longer filter it out, then the heart is sort of, being exposed to this disruption in a very delicate balance of electrolytes, and that can lead to disruptions in the way the heart beats, what we call arrhythmias.
Perfect. Thank you. We do have a question on Facebook. The suggestion is frequently to hydrate. Is a trip to the ED an absolute?
It's a great question. My belief is if you're seeing, this dark urine, that's a medical emergency. And we've had this situation recently, actually, where a child happened to be at a clinic visit and went to use the bathroom and came out with this dark colored urine. This is a child who happened to have Becker muscular dystrophy, but and really the child had no other symptoms, wasn't complaining of muscle pain, wasn't complaining of nausea or vomiting or anything else of that nature. And this child actually had a history of prior episode of rhabdomyolysis, which we didn't know at the time. But so my colleague seeing this patient saw when the child came out of the bathroom, had this dark colored urine, and, you know, asked, this was a non-neurologic colleague who asked what to do. And I said, we need to send them to the emergency department, and they did. And the patient was admitted to the PICU for a few days, really trying to flush that out. So even though that child didn't have other symptoms, just the dark urine, the CK was markedly elevated, and that patient was at risk for all the complications we just talked about. You know, needed a lot of IV fluids, and I'm not sure how that would be assessed at home necessarily. I think if you're having this profound dark urine, you really need a medical professional to assess, you know, safety for going for staying at home. That's my personal medical opinion, but others may differ in that. I'm not sure I would want to take the chance trying to resolve this at home through oral rehydration.
So definitely hydrate, but when you get to this point, still go to the emergency.
I will say this child had been given a sedating medication to help with the procedure, and so probably wouldn't have been able to orally rehydrate. He was sleepy. But again, my general advice to my patients is if you do see this, you should go to the emergency department, because you really don't know at that point if it's going to get worse. And the very least, they could make sure your heart rhythm is okay in the emergency room. They can give you IV fluids that you wouldn't be able to do at home. But I can understand why that might be a difficult thing to do.
And you said that this case had a previous case of rhabdomyolysis. Is that something that you see where if you've had it once, it is more likely to reoccur, or is it kind of a one and done if you continue to hydrate? What does that look like?
Right, and I think the prior episode was years ago. I've never actually seen this patient in clinic. They're followed elsewhere, and we're here for something else unrelated to they weren't in the neurology department. But I have not. Certainly it's possible, especially if you say exposed multiple times to known triggers, that sort of thing, if somebody didn't know their diagnosis. But I thought it was a little unusual. Apparently this child had 2 prior episodes, and it's not really clear, I don't have their records, what triggered those. It doesn't sound like it was an anesthesia type thing. So in this situation, the child was a little dehydrated. They had been NPO for a procedure. So they hadn't had any fluids for several hours that led up to this. And I guess were fighting, having their blood drawn, were agitated and, you know, kicking and screaming. So we're not sure if that was sort of enough to trigger it.
Okay, perfect. Another question. My child has darker colored urine quite often, especially in the morning. Since he hasn't experienced any of the symptoms that might indicate rhabdo, is there a concern? Should his neurologist or other specialist be checking blood work every 6 to 12 months to verify kidney function?
That's a great question. I think I hear this a lot from parents when they say darker colored urine, and that's to be expected in the morning, to have sort of that dark yellow, sort of concentrated urine from not having fluids all night. I think if it's sort of this color, that, you know, tea color, that's when I would be concerned. If it's just sort of that dark yellow, you know, without having the person in front of me, I'm not sure if they're referring to this color. This color, I think, would be a little bit more alarming. I would want to figure out what's going on there, but a dark yellow, not necessarily. It's not routine to check, say, a CK or kidney function per se. If there's otherwise no other concerns suggesting that there's kidney problems, when this happens, it's pretty acute. It's not something that, you know, just sort of lingers in the background for months at a time.
Perfect. Is the color change usually gradual or does it change within like one urination?
That's a great question. And so using the patient I referred to previously as an example, it was in one urination. So he had actually, for procedures he was having, had totally clear, normal looking urine, and then went to the bathroom again. And I don't know if it was an hour later or whatnot, but and came out with urine this color or even darker, actually.
And then is there a signal that there's damage to the kidneys? Is it temporary, permanent? Kind of sounded like it can be rectified if caught early enough. But I guess that's where I'll start with that question.
Yeah, no, great question. So certainly just in general, if someone's having kidney issues, they may have back pain or pain with urination, or I mean, those may be clues, but really it's a matter of having the tests done to show whether or not there's been injury to the kidney. And so there's blood tests that can test for that, creatinine, for example. Um, there is the possibility to have permanent kidney problems, kidney failure, if this is not caught and treated early. That is a possibility. And that goes for anyone who has rhabdomyolysis, a healthy individual, who, like I said, had a tree fall on their leg or something of that nature, where there's just this sudden massive muscle breakdown. I think it's really hard to tell just based on urine alone.
And then what would you what would be your recommendation for fluids, or would they kind of assess that at the hospital in terms of what's needed at that time?
Right, great question. Yeah, so the most emergency departments are quite familiar, even if they're not familiar with patients with Duchenne muscular dystrophy, they're quite familiar having patients with rhabdomyolysis and treatment for that, which would include large amounts of IV fluids until things sort of normalize. There's protocols in place for that for pediatrics and adults, and then obviously for a patient who has Duchenne muscular dystrophy with cardiomyopathy, an additional consideration would be contacting their cardiologist to make sure that the fluids aren't given too quickly and putting them into, over fluid type situation. So I think that would again be another reason to go to ideally the hospital center that is familiar with your child and their condition, but if not, the nearest hospital center to make sure that your child's stable enough for transfer to the ideally larger pediatric center that you're accustomed to.
Would you be able to send me kind of what is darker colored urine versus concern so that I could send that with the notes after the fact? Or
Sure.
with the recording, just because, I do think that that's something that, kind of like one of the questions, yes, dark colored urine, but this is kind of where you see that we're getting into the concern area.
Okay, sure.
Awesome. And then, can there be a correlation between rhabdo and developing kidney stones within our population? So within the Duchenne population?
So there are two distinct sort of mechanisms there. Certainly both can happen with dehydration. Kidney stones, if you're dehydrated, or certain medications can bring on kidney stones, different than the medications we talked about today. Whereas rhabdomyolysis implies an injury to the muscle membrane. So not that I'm aware of, is there a connection? I'm not a nephrologist, but I think they're two different pathways, but certainly dehydration could put you at risk for both of those things.
And then someone just had a statement that they had been led to believe that you can hydrate for 6 to 8 hours prior to going to the ED. So appreciate that feedback.
Right, I have seen that places, and so I think it's tricky. I think I'm a little bit more conservative in that regard. But if perhaps someone has a history and they've been instructed that that was okay by their physician to do, then I think, tailoring it to the patient, that's, something that they can talk about. But I think I err on the side of caution when I'm providing general advice to the public, because I'd rather, a patient get, additional fluids and care and so forth, and maybe not need it, than the opposite happen where we might not be able to reverse those changes.
Absolutely. Awesome. Does anybody else have any other questions? Those were very good questions.
They were very good questions.
If not, if anyone needs time to process, if anybody has questions after the fact, please feel free to send them to myself, and I can get them to Dr. Carla, and then we'll go from there. I don't see any other questions. I don't see any on Facebook, but if I've missed any, I apologize. I appreciate you all being here. Thank you for sharing your knowledge and expertise with us. It is something that, again, like I said, is a big question that I've seen several times. So I appreciate you, coming on and sharing the information with us. So appreciate all of you guys for being on and learning more about rhabdomyolysis today. And we appreciate you, and we appreciate your time, and we will see you on the next one. So thank you all.
Thank you.
Have a great day.